The goal of this short presentation is to provide a quick update on the role of magnetic resonance elastography in diagnosing and managing chronic liver disease. Magnetic resonance elastography is a technology for assessing the mechanical properties of tissue. Currently, the main application is to diagnose liver fibrosis. It's a very quick imaging technique, taking about 1 minute of imaging time. MRE has been available commercially as an upgrade for MRI scanners for more than 10 years, and there are more than 1,500 locations around the world that are equipped for magnetic resonance elastography. Chronic liver disease is a major global healthcare problem. There is a high prevalence of conditions that cause liver fibrosis, including hepatitis C, affecting nearly 200 million people around the world, chronic hepatitis B infection, and the growing epidemic of obesity and fatty liver disease. The important point is that if liver fibrosis can be diagnosed before it progresses to end-stage liver disease, it can often be halted and in some cases even reversed. So the challenge is to detect liver fibrosis while it is still reversible. At this stage, it's typically clinically silent and there is no anatomic change, so it's difficult to detect with standard imaging technologies. We want to make this diagnosis before it progresses to irreversible high mortality cirrhosis, which is also a pre-malignant condition leading to hepatocellular carcinoma. The traditional method for making this diagnosis is with a liver biopsy, which is invasive, associated with pain and complications, and even death. It's also expensive compared with imaging, and biopsy interpretation has poor repeatability with high inter-observer variation and sampling error. Here you see two parts of the same biopsy specimen. The one on the top shows almost no fibrosis, while the lower one shows that high levels of fibrosis in blue. We don't often discuss the diagnostic performance of biopsy, but it's far from perfect. In this study, 2 biopsy specimens were obtained from each of 51 patients. The specimens were then individually analyzed by a single pathologist in a blinded fashion. And in this graph here, we see all of the cases where both specimens from each patient were found to have the same stage of fibrosis. But in 41% of the specimen pairs, the staging was different in the 2 specimens. Here, for instance, is the group where at least one of the specimen pairs showed no fibrosis, in other words, stage 0 fibrosis. In 50% of the cases, the other specimen showed either stage 1 or stage 2 fibrosis. So histopathology is far from perfect in staging liver fibrosis. In an MRE exam, mechanical waves are generated in the liver using a source of vibrations that's placed against the chest wall. Propagating mechanical waves are imaged with a special pulse sequence in an acquisition that lasts only about 15 seconds. Here we see actual images of these waves in the liver and other upper abdominal structures. After the wave images are acquired, the data is processed automatically by the scanner to generate color-coded images showing tissue stiffness, as you can see here. We call this an elastogram. So here are 2 patients who have chronic liver disease. Is hepatic fibrosis present? You can't tell from these images. Here are the elastograms. And you can see that in this patient, the liver is very soft, similar to subcutaneous fat on the order of 2 kilopascals. This patient doesn't have liver fibrosis. The other patient has a very stiff liver, around 3 times normal. This patient has cirrhosis. MR elastography exams are displayed with a standardized color scale. Here you see images from 10 different patients. 2 of these are normal, and there are examples of liver fibrosis ranging in severity from stage 1 to stage 4 fibrosis. You can see how the color scale allows you to identify advanced fibrosis very quickly and easily. Now, because MRE is a very rapid technique, it can be added to a standard MRI liver protocol with very little or no impact on total exam time. But it's also possible to design a very rapid, focused liver exam consisting of just MRE and fat water imaging. Total acquisition time is about 3 minutes. We call this a rapid hepatogram, and it provides a detailed assessment of liver health in a very efficient fashion. We get fat fraction images, an estimate of iron based on T2 star, and MRE for detecting and staging liver fibrosis, all in about 2 to 3 minutes of acquisition time. So here are 3 patients with fatty liver disease. Can you tell by looking at these images if any of these patients is developing advanced fibrosis? Well, all of these livers have normal anatomic appearance, but that doesn't rule out the presence of fibrosis. This patient has normal liver stiffness and therefore no fibrosis. This patient is also normal. Yet this patient with normal anatomy has extremely high liver stiffness consistent with cirrhosis. So we have learned that some patients with advanced end-stage liver disease can have surprisingly normal anatomy. We've also learned that elevated liver fat alone has essentially no effect on liver stiffness. We can use MRE to follow patients with liver disease. This patient with fatty liver disease had a high body mass index of 31, elevated liver enzymes, and increased liver fat at 22%, much higher than the normal limit of 6%. The liver stiffness was elevated at 3.4 kilopascal, consistent with stage 2 fibrosis. Here is the patient 2 years later. Liver fat is a bit lower, but BMI is higher and liver enzymes are still elevated. The MRE unfortunately showed that this patient had progressed to end-stage liver disease, very high liver stiffness in the cirrhotic range. Here, MRE was used to monitor treatment response. This 51-year-old male with obesity and NASH was examined prior to bariatric surgery. The patient had elevated liver enzymes, very high liver fat at 30%, elevated liver stiffness at 3.2 kilopascals, consistent with stage 1 fibrosis. Here, 1 year after bariatric surgery, the patient's liver enzymes were normal, liver fat had decreased to normal at 4%, and the MR elastogram showed that the patient now has normal liver stiffness and excellent response. This 76-year-old patient had a long history of alcohol abuse. At the time of the baseline exam, the liver was very stiff at 5.5 kilopascals, consistent with cirrhosis. This patient stopped drinking and 9 months later had this follow-up exam, which showed liver stiffness had decreased dramatically to 3.4 kilopascals, consistent with a decrease from stage 4 to stage 2 fibrosis, an excellent response to management. The diagnostic performance of MRE has been established in many published studies. We can compare it to other clinical tests like AST to platelet ratio index, which is a blood test that's used to assess the likelihood of liver fibrosis. This figure shows the accuracy of this test for detecting stage 1 and greater, stage 2 and greater, stage 3 and greater, and stage 4 and greater fibrosis. This test performs better for high stages of fibrosis as we would expect. This is the performance of MRE as reported in 26 publications. Anything above 0.8 is considered to be useful. We now know that magnetic resonance elastography is as accurate as liver biopsy for staging liver fibrosis. A strategy that combines biomarkers can further improve diagnostic performance. In this recent study from the US and Japan, the investigators evaluated the performance of a simple combination of MRE with the FIB-4 score. The FIB-4 score is calculated from age, ALT and AST liver enzymes, and platelet count. They looked at the performance of the MRE FIB-4 combination in diagnosing clinically significant fibrosis F2 and greater. The results are shown here. In the U.S. cohort of 238 consecutive patients, the combined strategy provided an area under the ROC curve of 0.9, better than MRE alone and much better than FIB-4 alone. Similar results were found in the validation cohort in Japan. And most importantly, the positive predictive value of the combined strategy was very high, above 90% in both cohorts. And just recently, The same team compared the performance of MRE and FIB4 to a combination of ultrasound elastography, CAP, and AST that has been advocated for diagnosing clinically significant fibrosis. The performance of the MRE-based combination was much higher. MRE technology has been standardized across the MRI industry, using the same hardware, the same processing algorithms, and display parameters, so that if a patient has exams on two different MRI systems, it is valid to compare the stiffness measurements. Since 2018, there's been an international standard for performing clinical MRE. It's called the KIBA Consensus Profile for Magnetic Resonance Elastography of the Liver. You can download this at the KIBA website, as you can see here, and this provides extensive documentation on how to perform the examination and how to get the best diagnostic performance. Transient ultrasound elastography is widely used to assess liver fibrosis. Many studies have been performed to compare the diagnostic performance of FibroScan and MRE. This study, published in 2018, had a pooled analysis of 230 patients who had both examinations. Here you see the accuracy of FibroScan in blue, and here the performance of MRE in red, considerably better. Multiple studies have also shown that the technical failure rate for MRE is much lower than for FibroScan, particularly in obese patients. The higher accuracy of MRE elastography is probably due to the fact that it assesses a much larger volume of the liver. Transient elastography makes a measurement in a small region, approximately 6 centimeters below the skin surface. With MRE, the region evaluated is much larger and usually in multiple slices. And the distribution of fibrosis is usually quite uneven. And so if a FibroScan measurement was made at a location like this, for instance, you could conclude that the patient has less severe fibrosis than if you measured in this region. MRE samples a much larger volume of the liver, and this probably accounts for the higher diagnostic performance. For this reason, MRE has now been recognized by many professional organizations in their guidelines. The American College of Radiology gives MRE the highest rating for diagnosing liver fibrosis. The American Gastroenterological Association has suggested various ways in which it should be used, and the Society of Abdominal Radiology has said that MRE elastography is the most accurate, non-invasive method for diagnosing liver fibrosis. We now know that liver stiffness, as assessed by MRE, can be used to predict clinical outcomes. Here is some evidence that has just been published. This study looked at the long-term course of nearly 200 patients with cirrhosis over a period of 6 years after a baseline MRE examination. At the start, none of the patients had clinical evidence of decompensation, such as esophageal varices or bleeding. Based on the clinical course of this cohort over 6 years, this graph shows the probability of decompensation or death for different initial stiffness measurements. There is a very strong relationship between the clinical course and the baseline liver stiffness. For instance, this study shows that at 3 years after the baseline MRE study, a patient with an initial stiffness value of 5 kilopascals has a 20% likelihood of decompensation or death at 3 years. A patient with a higher baseline stiffness of 8 kilopascals has twice the probability of decompensation or death, about 40%, at 3 years after baseline in the MRE study. These two different patients have exactly the same fibrosis stage, F4, so the biopsy does not differentiate between them, but they clearly have very different levels of risk, which can be predicted with MRE. Results of studies like this are providing motivation for rethinking the heavy reliance on biopsy in clinical practice and making better use of quantitative non-invasive techniques like MRE in guiding management of patients with chronic liver disease. Another way to summarize the results of this study is that it shows that in patients with cirrhosis without decompensation, the probability of decompensation or death at 5 years is strongly related to baseline MRE stiffness. Each 1 kilopascal higher in stiffness corresponds to about a 30% increase in the probability of decompensation or death by 5 years. The study also evaluated the course of over 600 patients with clinical diagnoses of non-cirrhotic NASH. It showed that for each 1 kilopascal higher in stiffness as measured in the baseline MRE, the probability of developing cirrhosis within 5 years increases by 3 times. This once again provides strong evidence of the value of liver stiffness in guiding clinical management. Another exciting development is the recognition of the value of a focused protocol that could be called a rapid MR hepatogram. This examination consists of MRE and fat water imaging and requires only about 2 or 3 minutes of imaging time to provide a quantitative assessment of liver health. In the past, it was necessary to manually draw regions of interest in the elastograms and fat images to compute mean values for stiffness and fat fraction. New methods are now making it possible to automate this analysis. At the Mayo Clinic, we have developed a tool that is now used routinely to automatically analyze MRE and fat fraction images, producing a document like you see here. It automatically draws regions of interest in the 4 standard elastogram slices and compiles the stiffness values as you see here. It also automatically draws regions of interest and compiles results for liver fat. Studies have shown that this tool performs as well as an expert human analyst, eliminating the need to spend 10 to 15 minutes doing a manual analysis. This document is stored as an image or can be printed on paper. This technology should be widely available within the next year. Another exciting development is the wider introduction of the next generation of MRE technology, sometimes called 3D MRE. While the standard MRE technique that is deployed on more than 1,500 MRI systems around the world provides a very reliable measurement of liver stiffness, this next generation of MRE technology provides new, independent quantitative biomarkers. Research is showing that these new biomarkers have exciting potential to characterize processes like inflammation, portal hypertension, and vascular congestion, as well as predicting the histology of focal liver lesions. I'd like to highlight a recent study that used 3 biomarkers, liver stiffness, loss modulus, and fat fraction, to assess patients with fatty liver disease. This study, published in the journal Hepatology, performed advanced multiparametric 3D MRE in a cohort of 175 patients with NAFLD. Measurements of these 3 biomarkers were used to train an artificial intelligence algorithm to predict the NAFLD activity score and the presence or absence of NASH as determined at biopsy. The NAFLD activity score is a system used by pathologists to assess severity of NASH in biopsy specimens. It's been validated against clinical outcomes. They view the specimen microscopically and assign a subjective score for the severity of steatosis, inflammation, and cellular injury. These scores are then added up, and this represents the NAFLD activity score. The AI algorithm was then tested prospectively in a second published study referenced here. Here is one example. This is a patient who was evaluated prior to bariatric surgery for obesity and NASH. These images show the 3 biomarkers used by the AI algorithm. Stiffness is in the normal range, but fat fraction is very high at 26%. The AI tool made this prediction: high probability of NASH and a predicted activity score of 4 to 5. And these non-invasive predictions proved to be correct at biopsy. Here is the same patient 1 year after bariatric surgery. You can see from the outline here that the patient has lost a lot of weight, and the liver fat has decreased from 26% down to less than 4% in the normal range. Using these data, the AI algorithm predicted that the probability of NASH is now low and the activity score has decreased from 4 to only 1. Liver biopsy showed that these non-invasive predictions were again correct. I expect that these AI-assisted diagnostics will come into wide use. Many other applications of MRE elastography are being explored, including breast, kidney, prostate, and pancreatic imaging. But the next major emerging application is for neurosurgery, where the mechanical stiffness of tumors has a major impact on the difficulty associated with surgical resection. At the Mayo Clinic, we're using MRE as a practical tool for assessing the stiffness of intracranial tumors to aid surgical planning. So in summary, for this 2020 update, MRE technology is now widely available. The diagnostic performance in assessing liver fibrosis is now well established in the literature. Because it's non-invasive, MRE can be used longitudinally to assess progression and treatment response in chronic liver disease. The advent of advanced 3D MRE is providing new biomarkers which promise to further increase accuracy and specificity in evaluating liver disease. And finally, many new applications in other organ systems are emerging.